All right. Hello, everybody, and welcome to this webinar on the Reference Denture Technique. My name is Chase Thompson, and this webinar has been sponsored by Shining 3D. So we're going to be talking about the Reference Denture Technique, and then subsequently we'll talk about data acquisition using a desktop scanner. And more specifically, we'll talk about the custom workflow within the Shining 3D software and how you're going to set up a work order to capture all the data that you need to and align it properly to proceed with designing a new prosthetic for a denture patient. So, just to speak a little bit about myself, I'm a second generation denturist here in Alberta, Canada. So, my father was a denturist as well. I'm now a practice owner and I'm pretty deep into digital dentures. I do all my try-ins are 3D printed. All of my surgical immediate dentures are 3D printed, and all of my definitive dentures get milled at a milling center. The only time I ever do anything analog anymore would be if the patient's in a crazy rush and I don't have time to send away to a milling center to make something permanent. But otherwise, even if the patient's in a rush, I'll still give them the option for a 3D printed prosthetic. So I've been a clinic owner for 2 years, and it wasn't long into that I decided I needed to go digital, just to save my own back, but also to start producing something that was maximum quality that it could be for my patients. I went from working 50, 60 hours a week down to 30 or even fewer sometimes. I'm going to be taking over another clinic here pretty shortly. And I knew that if I wanted multiple clinics, which a lot of denturists do, I needed to bring in some digital workflows to make my workload manageable. So, what is a denturist? I'm sure that whoever's watching this around the world right now is thinking, what the heck's a denturist? But we're kind of like a dentist, but with a much more limited scope that has a heavy focus on removable prosthodontics. So there's only 2,400 denturists in Canada versus 21,000 dentists. We receive technical training, so we don't go to like a university and have a doctorate program or anything like that. It's far more technical. And we're licensed to oversee the entirety of the treatment. So we do all the treatment planning, impression taking for anything regarding removable prosthodontics. We can't make any permanent changes to dentition or the tissues. So we can't bond composite. We can't, drill in rest preps, and we can't place implants, but we can change implant abutments. We can make, screw retained prosthetics. That, of course, depends on where you are in the world. Every denturist kind of has a different scope depending on their regulatory body. But the common thread with pretty much all denturists is that we take the impressions and we take the occlusal records to fabricate complete and partial dentures. Now, denturists are unique in that we aren't just a clinician taking these records and sending them to a lab. We actually oversee the entire treatment. So we take the impressions, we make the bite blocks, we take the bite, we do the setup, we process the dentures, and we deliver the final denture. So we do all of the lab side and the clinical side of the work. And that level of exposure makes us really good at making dentures specifically. So for myself, I scan and print in-house. I'll scan impressions or models depending on the scenario. I find that, impressions don't scan very great. So I like to pour a model first and then scan that. And for partial dentures, I'm usually going to need something to process on anyways. So I might as well pour a model. 3D print all my try-ins, my surgical dentures, and any of my temporary partial dentures in-house. So some people in the world, you guys might call a temporary partial denture a flipper. So, somebody loses a front tooth and they're waiting to get an implant. That's an indication for 3D printing, but otherwise, pretty much all of my final definitive prosthetics get outsourced to a milling center. And almost all of my treatments follow the same kind of 3 steps. I scan in the data, 3D print something temporary or 3D print a try-in, and then mill the definitive prosthetic. I like to do most of my designs myself. I'll do some of them in exocad, but most of my complete dentures are done in a software called True Abutment, which is really similar to the Dentica software, if you're familiar with that. And then all of my try-ins, I 3D print in-house using DLP printing, or what you might call SLA. But ultimately, we're talking about resin printing for my try-ins, and resin printing for my surgical dentures, and resin printing for my temporary partials. And then for the final prosthetics, everything is getting milled out of PMMA. So what is the reference denture technique? It's pretty much exactly what it sounds like. You're going to use the patient's existing denture as a reference, or kind of as a benchmark point for the new prosthetic. A reference denture is essentially a combination of a reline impression and a check bite. Now, it's only that simple if the patient's existing denture allows it. There's a lot of advantages to the reference denture technique. To me, the biggest advantage is the patient adaptation and satisfaction. By making them a prosthetic that is very similar to their existing prosthetic, they have a way better tolerance for the small changes that you do decide to make. And essentially what you're doing is just building on what they do like about their existing denture and improving it from there. So it's really hard to lose with the reference denture technique. Of course, with doing anything digital, you kind of gain this accuracy advantage. The digital denture's accuracy on the intaglio side is comparable to that of an injection denture, if not better. And on the occlusal side, it's pretty hard to beat digitally set teeth. By setting teeth, by hand, you're always going to lose a little bit to human error, but digitally set teeth and then a milled prosthetic, you're not going to get any closer to a perfect denture than doing that. Data storage is a massive bonus for me. Not only do you have this idea that you can store the STL files of their existing denture, you can store the STL files of those impressions that you take, you can store the bite, and you can store the new denture as well. So should they break their denture or have any sort of issue with their denture, you can just send it away to have one milled or mill it in-house, or if they're really in a pinch, you could always 3D print them one as well. For most clinicians, the biggest advantage they're going to see with the reference denture technique is inefficiency. You get all of the information that you need to make the patient a new denture in a single appointment. You're getting your impressions, you're getting your bite registration, you're getting a VDO measurement, everything that you need all in one go. And realistically, because you're working with the existing prosthetic, a lot of clinicians find that they can skip the try-in appointment. I personally don't. I still do a try-in, but a lot of people can skip that and deliver a denture in only 2 appointments. And by doing things digitally, you're going to reduce adjustments, you're going to reduce revisions, and you're going to reduce remakes because the patient satisfaction is so much higher and the accuracy is so much better. Now, just because the reference denture technique is efficient and it's tempting to just kind of pump out the dentures doesn't mean you can do it on every single patient that comes through the door. The VDO, the occlusion, and the existing extensions all have to be reasonably accurate. So if the VDO is grossly over-opened, you're going to have a heck of a time working with that denture. You can certainly try, but it's going to be really difficult. If the bite is drastically off, again, you can work with that, but it's going to kind of add a layer of challenge and add a layer of difficulty that's probably going to lead to inaccuracies down the road. But some of these contraindications can be minimized by using the 3D printed try-ins for basically another reference denture technique at the second appointment, because then you can more aggressively alter those dentures, grind off occlusion, do whatever you have to get a better bite and better impressions. And just because this technique is easy doesn't mean you want to just be slapping impressions in there and slapping a bite out. You still need to focus on the basics of denture making. Don't forget about the basics of impression taking, preservation, retention, aesthetics, stability, support. These are all things that you can easily achieve with a reference denture technique. You don't need to be taking full injected alginate impressions and, nathometer, all of that to get a high quality denture. But this might be more technique sensitive than doing those things. So, getting into the technique itself, if a patient presents and the bites on video is good, aesthetics are great, they just have a little bit of wear on the teeth and a little bit of an ill fit, it's super easy. Reline impressions, grab that check bite with some PVS material and scan it in. You couldn't get anything easier. But most of the time, people have an acquired bite, or the bite is off, or the video is collapsed. And in those cases, what I like to do is just heat up a couple little tabs of Aluax, put it on the lower denture, and take a quick Aluax bite. That'll be always my first step with 80 or 90% of these patients. What's nice about that is you're also equilibrating the occlusal pressure then, and you'll be able to get a way nicer impression, with almost no effort. For myself, I like to do a monophase impression technique using 3M Improgum. I like it for two reasons. The consistency is phenomenal and the handling properties are phenomenal, but also it sticks to the denture really well. If you use just like a vinyl impression material, it flows nicely and they get a good impression, but you're going to have to use some adhesive on the periphery and then polish it off afterwards. Whereas I find with a polyether material, it just kind of sticks to the denture on its own, and you don't have to play around with any adhesive and worry about it delaminating when you're trying to scan it in. In areas where the denture extensions are short, so we fix the bite, we fix the video by using Aluax, but if the patient has a grossly underextended region on their denture, I like to use a little bit of periphery wax or utility wax. You could maybe use something like Kerr impression compound, but that is not fun to get off of the denture after the fact. So what I prefer to use specifically is the blue Culture Surgident periphery wax. So if you want to write that down, I'll say it again. It's a blue Culture Surgident periphery wax, and it works pretty great. I don't like to use it in the distal buccal because that's kind of an area that you go to grab to get the denture out after the impressions are taken, and you can deform that wax. But for the post-dam and for the linguals, it works phenomenally because it forms really nicely. It's not resistant to the patient's functional movements. And just like taking a reline impression, you want to start by taking the impression in the denture that has the worst retention, which is usually going to be the lower denture. Now, I like to do a closed mouth impression technique with functional movements, and this is really similar to like the Hiro Abe style impressions or the SEMCD impressions. Now, it's obviously cut short kind of a step because you're not taking those alginate impressions with the frame cutback tray, but you're following similar steps to shape the periphery. So first, you want to have the patient make an E or a smile and an ooh or kind of a kissy face shape, and then have them stick their tongue out and rapidly move it side to side, and then press their tongue against the roof of their mouth. I find that if you can do all of those movements 3 or 4 times in the course of the material setting up, you get a phenomenal impression that's really well formed to the patient's function. And then you'll also want to, on the upper denture, hold your finger on the patient's palate and have them open up and move their bottom jaw side to side a couple times. And that'll kind of shape that distal buccal region on the upper really nicely. So I also like to sometimes use some monophase impression material or utility wax to form a functional post-dam. I find that if you send your denture away to a designer, they might not always place that post-dam exactly where you like. But if you can do it functionally inside of the impression, then you're always guaranteed to get a really high quality post-dam and improve the suction of the denture and help keep food out of that distal extension on the upper denture. And then finally, in terms of the technique that I like to use, at the end of getting my bite set up and having those impressions in the denture, I trim it all up, put it back in the mouth, take a few photos for reference for when you're designing, and take a video measurement as well so that you know, oh, when I go to design this and put in the design software, I might need to close it a couple millimeters or open it a couple millimeters to correct the video. So if the bite is off or the retention is poor when you get to your 3D printed try-in, what's nice is you can just do everything that we just did again. You can reduce peripheries or you can build them up. You can grind out undercuts to get rid of pressure. And what's nice as well is if you prefer to use a PVS material at this stage, now you could use adhesive on the entire intaglio surface of the denture. And if you wanted to use that Cur compound, you don't have to worry about it coming off because you're just going to be throwing out these dentures after you scan them in. And if you want to get really complex, you could even use that 3D printed try-in to grab a face bow, or you could, grind away the teeth and throw a pin tracer into that 3D printed denture and get a pin tracing record, which would be good if you have a hard time getting a tactile bite. So that's kind of everything I'll talk about as far as the impression technique goes and the bite technique goes. Of course, this all goes without saying, but just don't forget the principles of making a high quality removable prosthetic. The bite must be perfect and those impressions have to be high quality, and you want to really focus on denture support and denture stability and denture retention when you're getting these impressions. But moving on from kind of the technique itself, we'll talk now about scanning and that data acquisition side of the technique. So depending on the scanner you have and the type of light that it uses, you'll probably have to use some scanning spray, especially on the occlusal side of the denture where it's highly polished. So first thing you want to do, trim the bite registration away from the anterior teeth. So the anterior teeth are vital for referring when you make the new denture. So you want to trim that bite registration out of the way. You will be able to align the bite still really easily with just those sections of bite registration in the posterior. So trim that away, give the dentures a good spray with disinfectant, rinse them off and thoroughly dry them. And now they're ready to handle with clean hands and head over to your scanning station. So again, depending on the scanner that you have, you're probably going to have to use some scanning spray. There's lots of brands out there. Some people even just use like dry shampoo to add some matte effect. But whatever you've got is going to work just fine. Just make sure that you're not ending up with any holes in your data. And don't be shy with the scanning spray. You can always just rinse it off with dish soap and warm water afterwards. And should there be any place where the pink denture base has shown through your impression a bit, then you'll also want to use a little bit of scanning spray on there as well. But I find for the most part, if you don't have any pressure areas, polyether and vinyl impression materials, even just the traditional ones, you don't need to go buy like the CAD specific PVS materials because most of these scan just fine. So the big three when it comes to, acquiring the data here, you absolutely must get the anterior teeth in your bite scan. You don't want to have any holes in your data, and it's better to have some excessive data to begin with and then trim it away later on in the scanning process. So of course, because we're sponsored by Shining 3D today, and I just do genuinely like Shining 3D, I'll talk a little bit about why I like to use Shining. Big one is no software fees. A lot of the salespeople for this equipment, they don't tell you ahead of time, but you end up with big software fees on lots of this scanning equipment that's out there right now. And it might include a 1-year free trial, and then at the end of that, they hit you with $1,000 or $2,000 software fee just to be able to keep on using the scanner and exporting STL files. And Shining is always updating their software just in the time since I bought my scanner just over a year ago. they've gone through some major updates and some major overhauls to improve their software, which was good to begin with, and it's just getting better and better. Shining also has an ever-expanding ecosystem. They just came out with their face scanner. They've got 3D printers. They're constantly adding new validated resin for their printers. Just a phenomenal ecosystem, and a big community of users as well. Because so many other clinicians out there have Shining scanners, you can always reach out to one of them when you're having issues, myself included. Customer support with Shining has been fantastic. If you reach out to them, you always hear back within a day. If you need to hear back sooner, you probably want to reach out to your reseller. But for myself, they do the trick. And as far as the price to performance ratio goes, you really cannot beat Shining, in my opinion. You really do get a lot more than you pay for. So moving on to the actual scanning process. Now, to set up your order correctly, you're going to want to go to that little kind of settings cog in the top right. Click that, go to order mode, and switch it over to clinic mode. Clinic mode is just a little bit more customizable in my experience. So once you're in clinic mode, you'll come back over and start setting up your order. You'll want to put in the patient's name. And then I always just choose the 1-1 and the 4-1 for anatomic crown, and then go ahead and click scan. The reason we're doing this is just to indicate to the software that we're going to be scanning both arches, but we're going to customize this workflow more specifically in the next step after we click scan. So you click scan, it'll take you to a page, and you're going to want to click that thing that's circled. I've circled it in red there. It's kind of like a little settings button with some lines. So click that. It's going to come up with these kind of 3 dialog boxes: upper jaw, lower jaw, and occlusion. For the Reference Denture Technique, you'll want to choose upper jaw impression, lower jaw impression, and then occlusion impression, and then mush bite. So you go ahead and click apply, and then we can start getting set up to scan. So for your bite, this is always how I set up my bites. I use the little flat plate with the 3 prongs on it and a rubber band. You can just go to the dollar store, get yourself a kit with like 200 or 300 rubber bands of all different tensions and sizes. And then you'll have a big selection to choose from depending on the size of the denture or the size of models. And you want to use a little bit of that blue putty as well that comes with your scanner. Use a little bit of the blue putty down on the intaglio of the bite, or use some on the occlusion side of the impression scan. And spray it up with scan spray liberally if you're worried about not being able to capture all the data. So the first thing it'll have you scan is going to be the bite registration. So you use the add scan feature as much as you have to. You're just going to click scan to begin with, and it's going to automatically do its own thing. But inevitably, because it assumes that you're only using this to align the files, it doesn't capture detailed data. So you want to make sure, most specifically, that you're getting enough data to align your files, but as well, you're getting all that data from the anterior teeth so that you can either copy the existing denture's plane of occlusion or make the changes that you've noted from kind of the clinical part of this. So again, what you'll do is, if you're missing data, you're just going to pan around the denture over to the angle that you know that you need to capture better. And then you'll click that little kind of play button down in the bottom that I've circled in red. And that'll help you gain more data and get a more accurate scan overall. So when you're scanning the impressions, I'm just going to go kind of back here. So when you're scanning your impression, you're going to want to press the occlusion into some of that blue putty, and that'll hold it more than secure enough to proceed to scanning. So use a flat plate. You can use the one with the 3 prongs or the one without. It doesn't really matter, but you'll want to use a flat plate, press the occlusion into that putty, and then go ahead and hit scan. Now, for these, they almost always scan just fine on their own. You usually don't have to use the add scan feature too much. Sometimes you'll have to use it on the retromolar pad region of the lowers, or in the facial area of the maxillary ridge. For any areas where there's just a little bit too much undercut for the scanner to pick up, you can do two things. One, it's an odd tip, but I find that turning off the lights in my scanning room and then trying to scan that area does help more of that light reach that area so that it can get scanned. Or you can wait until later in the pre-design phase and then use the filling holes tool. And if it's anything small, you don't have to worry about it causing an issue with your fit later on. The artificial intelligence in this software is really fantastic at kind of estimating how that would look in that area. So as long as you have set up your order correctly and you've got adequate scan data, the scans should align pretty nicely on their own. Now, if they don't, then you can always click these two squares down at the bottom, and then you can select 3 points and then manually align the scans. But your manual alignment will never be quite as accurate as the automatic alignment in my experience. And if you don't end up with properly aligned scans at the end, like if something looks really way off, it's usually not because of the scan data so much as it is because you set up the order incorrectly. So if you set up the order and you chose, 2 models in occlusion instead of mush bite, then it's going to try to align what is essentially inside out data with right side out data, and it'll get really confused and you'll end up with some wonky stuff. So if you end up with an alignment issue, go back to that kind of menu where you're doing the customized scan workflow and double check that all your settings were correct. Now, you'll know that it's scanned correctly when you see kind of this leopard print appearance on the dentures. You can kind of see it in this image there in the distal of the lower. And that's how you know that it's aligned correctly and it's aligned successfully. If it doesn't look like that, usually it'll be grossly misaligned. But if it looks like that, you're good to go. You can click next and head on into the pre-design phase where we'll trim up the data. So what you're going to do is select one model at a time. So on the top left, you see those little check marks. You can uncheck one of the models, just leave one of them on there. And then you'll go over to the far right and there's a little kind of icon with some teeth and an X. You'll click that and then it'll come up with a paintbrush tool. I like to use the paintbrush tool to eliminate my data just the way my brain thinks, I guess. That's what I prefer. But you can also switch over to this little kind of rope looking lasso guy and you can section off the data by trimming it away, kind of circling it and then trim, circle it and trim. But I prefer to use the brush tool. Now, you have to trim away data. You're going to end up with lots of excess data from this technique, and it'll make the file sizes absolutely insanely massive, and you'll run out of space on your computer in no time if you choose to keep all that data. So it's better to trim it away at this stage and then save it in the way that is going to use the least space. You'll also find that all your design programs like 3Shape and Exocad and True Abutment or Dentka, they function way slower when you have too much data. If they're working around files that are 40 or 50 megabytes instead of 10 or 15, it slows them down a lot. And for your own convenience, you'll also want to trim away that data. The trimmed data is just cleaner to work with, cleaner to design on. Even just for sharing to your designer, there's always going to be limits on things like Google Drive or Dropbox, and you start paying when you exceed those limits. So keep your data small, keep it clean, and everyone's happy. Yourself, your designer, it's much easier that way. And then in this stage, you can also fill your holes. So if there was any areas, sometimes when you get an impression of an extraction site or there's a really deep undercut on the scan, it doesn't scan it in that spot properly. What you're going to do is click the button right beneath the the removal tool, and it's got a picture of a tooth with a hole in it. You'll click that guy, and then it'll come up with a little dragging bar. You can scale it up to 100, click the check mark, and that'll fill all your holes for you really nicely. I recommend that you do that after trimming your data. Otherwise, it might fill holes in places that you don't want them filled necessarily. So once you're done all your trimming, you filled your holes, you're happy with your data, you'll want to proceed to exporting your data. So after you trim all your data, then you'll want to just click this check mark, you're happy with it, and you'll say, yep, proceed to send. And then you'll click finish, and then it'll take you back to your dashboard. Once you're back on your dashboard, you'll have all your cases shown there, and then you can click this little file folder with a search guy on it. Click that, and it's going to pull up a file on your computer that looks like this. And when you zoom in on my screen, you can see that it says, lower jaw, upper jaw, total jaw. You'll want to use all the ones that are the STL files. Those STL files are the ones you're going to be using for your design, or, sending away to your designer for them to do the design. And that pretty much wraps up the whole technique. So, you'll take your impressions, scan it all in, and then export it to whatever your design software is going to be. So should you have any problems that you need to troubleshoot, number one, calibrate your scanner. I like to calibrate my scanner once a week, once every 10 days, but your Shining software will tell you when your scanner was last calibrated as soon as you plug it in. And if you start getting up to, 20, 30 days, you might start seeing issues. You'll want to recalibrate it. The reason for this is because desktop scanners use a fixed coordinate system, and that fixed coordinate system depends on being calibrated correctly. And all your scans are going to come out cleaner, and they'll align nicer if your scanner is properly calibrated. And in a dental lab, there's a lot of vibrations. There's a lot of, smacking on the table. It's pretty easy to get those things out of alignment by accident. So make sure you calibrate it now and then, especially if you're having issues. Next thing, verify your settings. If something's not aligning correctly and your machine is calibrated, it's probably because you chose, models and occlusion, or you chose a model instead of impression when you should have chosen impression. Because outside of those two things, I have never had an issue with my scanner. And I've actually never had an issue with the calibration either. I just calibrate it to be safe, but I've never ever had an issue with alignment if my settings are correct. Now, if you didn't get enough data, you'll also have some trouble with aligning the bite. But if you didn't get enough data, you can either restart the entire case and import the data for the scans that were good enough, and then just rescan for the scans that were bad. Or you can go back in the workflow of that already existing patient file and just rescan that one step that was bad. Now, if you're having trouble with exporting the data or having trouble at any time, I suggest you reach out to your supplier. Your supplier or your reseller is going to be able to answer your questions most clearly. And if you haven't bought a scanner yet, make sure you vet your supplier for support. If they're not going to be there for you to just even get set up in the first place, you're going to struggle with going digital. Going digital is a massive change of pace for your entire clinic, for your entire workflow. And if you don't have the proper support in place, you're going to have a heck of a time. And realistically, you'll probably just give up on it if you don't have someone that's there for you. So that's the entire presentation. Thank you all for coming and watching and supporting myself and supporting Shining. If you have any questions, you can ask them now. Or if you want to save them, you can reach out to me on Instagram. Just send me a DM. My Instagram is Chase Thompson DD, and I'm more than happy to respond to you guys there. And I post lots of my denture content there as well on my stories. So anybody who's got questions right now, I'll start by answering any that are in the chat, and then we'll answer some as we go here as well.